Good morning, everyone. Welcome to the next episode of Chai Pe Charcha. I, Dr. Saurabh Mundhada, editor, Chakshu, Team OSN 2022-23, welcome you all for another session in Chai Pe Charcha. Today, we will be talking on how to give intravitreal injections. Now, everyone has an opinion on making a perfect cup of tea, whether the debate is milk in first or after, the length of the time the tea needs to be mashed, even the type of teapot in which the tea is brewed. So today we will be speaking expert guidance for the same perfection in how to give intravitreal injections. And for that, we have invited Dr. Shamik Mokadam, our own faculty and expert in the field. Intravitreal injections enable highly targeted drug therapy, maximizing therapeutic drug delivery to the posterior pole while minimizing systemic toxicity. With the increasing use of intravitreal anti-VEGF agents in the treatment of neovascular ARMDs, diabetic macular edema, retinal vein occlusions, and various other retinal disorders, these injections have become the most common ophthalmic performed procedures. The single most important thing to remember is that intravitreal injection is an intraocular operation and it should be treated equally seriously. The most devastating complication is endophthalmitis, and we must take every possible precaution to prevent infection. So today we have our expert, Dr. Shamik Mokadam, young, dynamic, and very enthusiastic vitreoretinal surgeon. He has done his DNB from Arvind Eye Hospital, Tirunelveli, and his MRC ophthalmology from same institute. He has also done his vitreoretinal fellowship from Arvind as well as from Lions Eye Institute, Perth, Australia, and is currently working as a vitreoretinal surgeon at Anjani Eye Hospital, Nagpur. To his credit, hold many posts. Like in OSN, he was secretary OSN. In WAS, he was executive committee member. He is treasurer and vice. He has also held vice chairman scientific committee WAS. He is a very meticulous surgeon, and we expect him to teach us how to prepare preoperatively, what to do intraoperatively, and how to manage postoperatively the patient posted for intravitreal injections. Over to you, Dr. Shamik Mokadam.
Good morning, everyone, and thank you for the introduction, Saurabh. Those kind words are really kind for me. I'll just, is it okay if I share my screen?
Yes, sir.
And I'll have a small presentation going on in the background. So I'll be talking on intravitreal injections. Saurabh has given a rough idea as to how we are going to move ahead in this presentation. So the most common indications are diabetic retinopathy or diabetic macular edema, retinal vein occlusions and the related edema that is there, age-related macular degeneration, the wet type, and some other conditions wherein the macular edema is seen. So I have already mentioned the indications. These are the anti-VEGF injections are usually done at 4 to 6 weekly intervals for 5 to 6 months, depending on the condition that we are treating. And in certain conditions, we may have to use steroid injections, which are done more than a few weeks apart, commonly around 2.5 to 3 months apart. So the arsenal that we have with the intravitreal injections includes the ranibizumab, bevacizumab, and aflibercept. These are the original products, wherein Lucentis is a ranibizumab original product, Avastin is bevacizumab original product, and aflibercept is in the form of Eylea. Amongst these, the Lucentis and Eylea are single dose vials, which are considered slightly better as regards the infectivity or the safety concerns are. compared to the multi-dose vial, because in a multi-dose vial we try to prick the rubber stopper of the vial every time that we need the injection to be withdrawn from the bottle and done to the patient. So I would also prefer a single dose or a single use vial, wherein it is a metered dose which can be only used for one patient, and the vial is discarded after use. The other medicines now available in the Indian market are biosimilar products of ranibizumab. Many companies have come up with different biosimilar for ranibizumab. First one to come out was Intas. The next one was Reliance with their Ranizurel. Uh, then came Lupin and Sun Pharma, and even Cipla has its own biosimilar. Bevacizumab also has a biosimilar produced by Zydus, and aflibercept biosimilars are in the pipeline and will be available probably in a couple of years down. So when it is a patient that we have decided to go ahead with injection for, the patient is prepared outside the OR, and the necessary consents are taken from the patient and their relatives regarding the intravitreal injection, and also all these details about the intravitreal injection, about the complications, the side effects, everything is explained to the patient outdoors. Consent is taken. Once the consent is taken, the patient is prepared outside the OR, like so, where we would paint that part of the that side of the skin on that side of the face, where we are on the eye which we are going to do injection for. The eye to be injected is marked, and once this is done, we instill xylocaine or proparacaine eye drops in the eye to be injected, followed by a drop of povidone iodine. Then we take the patient to the OR, and the patient is made to lie down comfortably onto the operation table, and the patient's eye is prepared with the conventional method of cleaning and draping. During cleaning, we have to take care that uh, the whole portion of the skin on that side of the eye is taken care of, cleaned well. The brows are cleaned well, and once that is done, the patient is draped, and the eye of that patient is draped like so. And once this is done, we put a speculum. I personally prefer a guarded speculum, or guarded speculum to be used for injections. The speculum keeps the eyelids away, and so does keeps and the draping keeps the lashes away from the main injection field. Again, on the table, we instill a drop of paracaine into the patient's eye and a drop of povidone iodine before the injection is being done. So once this is done and the eye is instilled with povidone iodine, we clean up the excessive povidone iodine that is there, and then depending on the nature of the patient's eye, that is either phakic, pseudophakic, or aphakic, we would decide on the distance at which the injection is to be injected. This is generally measured with a vernier caliper. I personally prefer a 3.5 to 4 distance from the limbus for patients who are phakic. Patients who are pseudophakic or or aphakic, I would prefer a less than 3.5 or 3.5 side from the limbus. Once this is decided upon and this is marked, we would then the conjunctiva is moved slightly away from the side, and then once if you नहीं, ये थोड़ा सा रिवाइंड कर रहा हूँ, एक सेकेंड. हाँ, so once the site is marked, the needle is passed slightly horizontally initially, and then it is turned perpendicular to the globe. So this is how the procedure has to be done. And once we are sure that the needle is well inside the globe, we would inject like so. So this is how the procedure we follow at our setup as well. A few things that I would want to mention here as well are there are certain complications which can happen during the procedure and which can be easily avoided. One of them is complications during the procedure or during there are a few complications
रिफ्रेम करके पूरा ही बोल दो एक बार, पूरा रिफ्रेम कर लो, आपको क्या बोलना है फिर बोलो, नहीं तो फिर आधा आधा अटक जाएगा.
हाँ. So there are a few complications that can occur during the procedure and later in the procedure as well. If our marking is well and we are sure of the phakic or the pseudophakic nature of the eye, the chances of certain complications can be reduced. The commonest ones include lens touch or cataract formation during the procedure, in which the needle which is passed inside touches the lens on the back side, of the lens, and the lens is punctured. The lens capsule gets punctured, and it forms a cataract over there, localized, or say it can develop a complete cataract in some time. So this can be avoided by being careful enough or doing the procedure, watching with the microscope and seeing the tip of the needle which is away from the posterior lens capsule. I also try to avoid passing the needle all the way to the hub inside the eye. So that also reduces my chances of doing a lens touch on the posterior side. I prefer doing triamcinolone in the inferotemporal quadrant, while I prefer doing all the intravitreal anti-VEGF agents in the superotemporal quadrant. This is basically more of a personal favoritism, because I don't want to, I have a firm brow on which I can keep my hand steady while I'm doing my procedure in the superotemporal quadrant in either of the eye. Whereas when I have to do a inferotemporal approach, I have to turn my hand around the eye and try to do it with lesser of the support that is there. So this is one way of avoiding a lens touch. The other complications that can occur intra-op are either vitreous hemorrhages, which is really not very common, but then it can happen, and it is not unavoidable sometimes, because we don't know where the blood vessels are within the pars plana, and you may end up having bleeds from there. But then we can always avoid the dead temporal or the nasal approaches, that is 3 o'clock, 6 o'clock, 3 o'clock and 9 o'clock positions, where we know that most of the large vessels are. The third complication that can be there is retinal detachment. Well, that is if your marking is perfect and if there is no abnormalities in the retinal within the retina, the chances of retinal detachment are less if the marking is perfect and if we are injecting from the pars plana. If we are slightly more posterior, the chances of retinal detachment are on the higher side. So we have to be very careful as to how and where we are injecting our injections. So I'll show a video of triamcinolone being injected. This is an old video, and this was when I was doing my fellowship in Arvindai Hospital. So this is a video from there. So we withdraw uh, triamcinolone about 0.1 ml into the syringe, 1 ml syringe, and rest of the procedure is practically the same, except that the needle that is to be used for triamcinolone has to be a 26 gauge needle and not a 30 gauge needle like we use in common anti-VEGF injections. The reason for using a 26 gauge needle in triamcinolone injections is because of the triamcinolone being a suspension, and the particles from the suspension may clog the 30 gauge needle, and we may not end up doing the right injection inside the eye, right volume of injection inside the eye. So the needle we have to use there is a 26 gauge needle. Um, the other complications are the rarer ones, and the most dreaded one is endophthalmitis. And to prevent endophthalmitis, we should take as much antiseptic precautions as possible. Nowadays, there are companies which are providing with these injection kits, which include all required material for an injection, and there are various kits that are available. It is up to us how much we want to do and how much we want to spend. To prevent infection, not only is the antiseptic or aseptic precautions to be taken, like the set that I just showed, we can also take care of preventing an intravitreal injection related endophthalmitis by using either pre-filled syringes or single vials, single dose vials for these injections. Though the incidence of endophthalmitis post-injection are less, but we have to understand that these individuals or these patients are going to require injections every month or say every 3 months, and so the chances of infection are there every time that we are going to inject that eye. So we have to consider this, that in a manner that every time doing the injection, there is a possibility of 1 in a 10,000 or 1 in 1,000 chance of an endophthalmitis in a patient's eye post injection. As per guidelines formulated by AIOS and VRSI, intravitreal injections in India should be done in the operating room under all aseptic precautions. So these are a few of my points that I prefer doing in my setup, and I prefer doing all my injections in OR setup or operation room setups only.
Thank you, Dr. Shamik, for a wonderful presentation. And most importantly, you meticulously showed how to prepare the patient preoperatively, how to prepare and give injections intraoperatively, and how to take care of the postoperative part. We have a few questions to you related to the same topic. A few we like you to answer. First, what are the conditions you generally treat other than diabetic retinopathy with intravitreal injections in general?
I had mentioned it earlier also, Saurabh. The common conditions include retinal vein occlusions and age-related macular degeneration. Other than these, we can use steroids in chronic cystoid macular edemas related to uveitis, but that is relatively less. We would prefer doing a posterior subtenon's injection of triamcinolone than trying to do a intravitreal injection.
Yeah. Since these injections needs to be given multiple times in some patients, so do you follow any specific regime?
Yes. See, intravitreal injection, it depends what kind of molecule we are using. Commonly, the ranibizumab and the bevacizumab acts for about a month. So we have to do an injection to the patient's eye every month once, say about 4 to 6 weeks में एक बार. Uh, And we have to understand that diabetic retinopathy, yeah, vein occlusion related edemas are a long-standing or a long-term treatment. So I commonly perform injections once every month for about 4 to 6 months in these individuals. In next 4 months, if the edema, 4 to 5 months, if the edema is not subsiding with just anti-VEGF injections, I would switch over to steroid injections inside the eye. This is regarding macular edema. In case of ARMD, wet ARMD, there are two different regimes which are very well known and very well documented in various studies. And the common ones are PRN, or which is the in which we treat for 3 months, then we observe, and as and when required, we would do injections to the patient's eye. The other one being treat and extend, wherein we continually treat and extend, wherein we continue the injections to the patient's eye. Initially, we do 3 injections once every month. Then we do another 3 to 4 injections once every 6 weeks. And then we proceed with once every 2 months. And then the condition, till the time the condition is totally under control or there is no edema subretinal fluid in the patient's eye. So these are relating to anti-VEGF injections.
Okay, you have already mentioned most of the complications, if at all encountered, and what are the chances of them. So now, just last question: since these patients needs multiple injections, so how do you manage the expectations and outcomes of these patients?
Right. This question actually I should have tried to embed this in my presentation itself. I prefer counseling the patient beforehand. I would explain to the patient the condition, the need of the treatment, and the outcome that he or she should expect out of the final out of this treatment. So the outcome I always try to explain to the patient and kind of underline it, tell it twice or thrice to the patient whilst I am doing my counseling. And I would tell them that, we are not aiming at improvement of vision, and we are trying to stabilize whatever is there with us. Instead of giving a false hope to the patient that, injection लगा दिया कि पूरा ठीक हो जाएगा, ऐसा ना बताते हुए I'll tell the patient that we are trying to save whatever is there. And for that, we will require at least 4 to 5 injections to start off. If required, we may need more. So the patient's mind is already prepared beforehand that we are going to require more number of injections and the outcome is going to be this. So then the patient is mentally ready for as many injections or whatever the treatment be as required.
Excellent talk, Dr. Shamik. To sum up, will you like to have some take-home message for our audience?
The take-home messages are, I would do a couple of take-home messages. One is counsel the patient and explain the patient the outcomes that they are going to expect rather than what they want. They need to be explained that this is something that we are trying to save. That is one. And the second one is that I would prefer to suggest everyone to move over to single dose vials rather than using multi-dose or the ones which are in the form of Avastin or the Zydus related bevacizumabs. So single dose vial should be the norm from now on because there are so many others available in the market which are good, and safety wise single dose would always be better.
Okay. Thank you everyone for your patient listening. This is Dr. Saurabh Mundhada signing off, and see you in the next lecture on Chai Pe Charcha.